Thank you to the organizers. Thank you, David. Thank you, Isaac, for this exciting opportunity to talk about hemotype SC. So my name is Eric Sorrell. I'm a product manager at a very small diagnostics company in Los Angeles, California, called Silver Lake Research Corporation. And I'm here to talk about this product, hemotype SC, which is a rapid and inexpensive point-of-care blood test for sickle cell disease. So I don't need to talk about the statistics of sickle cell. We've heard it over and over, but just by means of introduction, I'm going to state a few statistics. Hundreds of thousands of children are born with sickle cell disease every year, and without proper treatment, which springs from diagnosis, of course, sickle cell has up to an 80% childhood mortality. So, of course, newborn screening followed up with proper medical attention has been shown over and over again to significantly reduce sickle cell disease mortality. However, newborn screening is, of course, not widespread in low-resource regions, and these low-resource regions are the regions where sickle cell disease is most prevalent. And so, therefore, an unacceptably high level of sickle cell disease-related childhood mortality still exists to this day. So our objective was to set out to design a point-of-care diagnostic test for sickle cell disease that is suitable for these regions, and we believe we have accomplished this objective with hemotype SC. So this is an affordable, rapid, simple, and highly accurate point-of-care test. Everyone knows the epidemiology. Sub-Saharan Africa and central India can experience up to a 40% prevalence of sickle cell trait, depending on the region, with pockets in South and Northeast India also experiencing that prevalence. And shown in the top right is that sickle cell disease kills and kills early if not diagnosed. So in the first 2 years of life, the majority of deaths happen. And I guess you can't really see this graph at all, but what this shows is that with hydroxyurea treatment, the probability of survival goes up to nearly 100%, as opposed to a line that goes down here, which shows that when you're not treated, there's a significantly lower probability of survival. And that's reinforced with this graph, which we've seen multiple times this conference as well, which compares different sickle cell disease cohorts, tracking newly diagnosed individuals over time, with the most recent cohorts experiencing the highest fraction surviving, likely due to proper diagnosis and medical treatment. So how is sickle cell disease diagnosed? We all know the gold standard methods are highly accurate. HPLC, isoelectrofocusing, and electrophoresis. Some machines are shown down here. These are great methods for identifying and diagnosing the disease, but these methods are not suitable for low resource settings, in our opinion, for the following reasons. They require relatively expensive equipment. They require electricity, dedicated and trained personnel. Relatively large amounts of blood need to be collected, which can be an issue with newborns. And of course, they're not point of care in most cases. They require sample delivery away from the point of care, and there is a time delay in result acquisition, which leads to loss to follow-up. So the impact of this problem, of the lack of an adequate point of care device in low resource settings, is exhibited with these stats. So 300,000 children are born with the disease, 5.5 million are born with the trait every year. So that's a huge amount of people. 25 million of these individuals are currently afflicted in sub-Saharan Africa and India. 80 to 90% of all afflicted newborns are in these regions. And again, I've already stated the high death rate at an early age, so universal newborn screening needs to be enacted in these regions and then followed up, of course, with proper medical treatment to reduce mortality. So we're very excited to present this new point-of-care diagnostic test, hemotype SC, which we believe solves the problem. So hemotype SC is very simple, rapid, accurate, and inexpensive. It was developed using Silver Lake Research's Enhanced Affinity platform. So this Enhanced Affinity platform is a proprietary in-house technology which the company has used for 20 years to develop highly specific monoclonal antibodies and then pipeline these antibodies into lateral flow assay strips. So if anybody in the audience remembers the Flint, Michigan water pollution crisis, another product from Silver Lake Research was the most used test in identifying lead contamination in water. This was a water-safe test which can detect a single atom of lead in a small volume of water. So the products coming out of Silver Lake Research have been high quality and accepted by various state governments in the US for over 20 years. So using this platform, scientists at Silver Lake Research identified 3 monoclonal antibodies for sickle cell disease relevant hemoglobins. And these are hemoglobin A, S, and C, which differ at the same position by a single amino acid in the beta globin gene. So as I'll show, these 3 monoclonal antibodies have ultra low limits of detection and are highly specific for their antigen. So these antibodies were engineered into a lateral flow assay, hemotype SC, which is used to detect these hemoglobins. It requires 1 microliter of whole blood. The results can be read at the point of care, at this table even, in 5 minutes. And there's a simple 3-step protocol that anybody, even a child, can run. So I have just 2 hard data slides that show the specificity and sensitivity of the antibodies that have been engineered into the lateral flow assay test strip. In order to show the specificity of these antibodies, the scientists at Silver Lake Research carried out a competitive ELISA assay. And so a competitive ELISA assay is exhibited here. So 3 different ELISA plates were coated with hemoglobin A, hemoglobin S, or hemoglobin C, respectively. The 3 antibodies, either A, S, or C, were then mixed with whole blood containing the following phenotypes, which are listed here, either AA, AS, AC, SS, SC, or CC. So the antibodies were mixed with whole blood containing these hemoglobins and then applied to the plate, and then the scientists looked for ELISA signal. So if we just look at the situation of when the monoclonal antibody for hemoglobin A was mixed with these blood types, we see that when the antibody was mixed with blood types that contain hemoglobin A, so AA, AS, or AC, there was no binding of the antibody to the plate whatsoever. So the hemoglobin in the blood bound to our antibodies and completely inhibited the binding, or as you would say, competed away the binding to the plate. Whereas when the antibody against A was mixed with blood that did not contain A, but instead was SS, SC, or CC, there was efficient binding to the plate and no competition whatsoever. So that showed how specific the monoclonal antibody against A is for binding to its respective hemoglobin. And on the other hand, when the antibody against hemoglobin S or C were mixed with any of these, in any situation, the antibodies did not bind to the hemoglobin A-coated plate. So again, exhibiting the specificity. So just quickly touching on the S-coated plate and C-coated plate. On the S-coated plate, the antibody against A or C did not in any case bind to the plate, whereas the antibody against S only bound to the plate when mixed with blood that did not contain S. And the same thing occurred with our antibody against C. So there was virtually no cross-reactivity, and the antibodies are highly specific for their target. I apologize for the colors. You probably can't see it very well, but the same experiment was run, but slightly differently, where the whole blood was now diluted and then mixed with the antibodies. So this was done to determine how much of a dilution of whole blood can still inhibit the binding of the antibody to the plate, or in other words, how sensitive are the antibodies. And so in the upper graph, we have our antibody against hemoglobin A mixed with either AA, SS, or CC blood, and then applied to the hemoglobin A-coated plate. So we see that the antibody bound to the plate and gave a lot of signal when mixed with SS or CC blood, but when mixed with the AA blood, even a 1 to 100,000 dilution of the blood still almost completely inhibited binding of the antibody to the plate. So the antibody is extremely specific, and I'll tell you the exact limit of detection on a later slide, but we see just about the same statistics with our antibodies against S and C as well. So there's no cross-reactivity at any concentration measured, and the IC50 was over 1,000-fold lower than for the non-targeted hemoglobins. In fact, there was no IC50 measured for the other hemoglobins. And very quickly, many lateral flow assays are designed in the sandwich assay format, and so this can actually be a problem when measuring samples that have a very high concentration of your analyte, which can occur in sickle cell disease where the hemoglobin levels can be quite high. So in particular lateral flow assays that use sandwich technology, you can have false negatives occurring due to the prozone effect, where the very high level of hemoglobins can just bind to the antibodies that are involved and inhibit their interaction. So as I mentioned earlier, this assay is a competitive immunoassay, which is not subject to this prozone effect, and thus has ultra low limits of detection. So many of you in the audience know what a lateral flow assay strip looks like typically. You'll have a sample pad to which your sample is applied. In many cases, you'll have a conjugate release pad which interacts with the analyte in your blood and travels up the membrane. And then you will have, in many cases, antibodies sprayed on a test line and a control line, which interact with your conjugate and the analyte in the sample and produce your lines that you read. So this is kind of how our test has been engineered. It looks just like this. We have a sample pad. On the conjugate pad, we have hemoglobin A, S, and C conjugated to red colloidal gold. So what happens is the blood goes onto the sample pad, it combines with the hemoglobins on the conjugate pad, and then travels up to where our antibodies are sprayed on this nitrocellulose membrane, and you'll have a line for CSA and then a control line. And so the competitive nature of that assay means that any hemoglobin in the blood that is applied to the sample pad will compete with binding of the red labeled hemoglobin to the antibodies, and you will have a missing line. So you look for the missing line. And I'll touch on this again on the next slide. So this is, for some reason, nothing in my talk is showing up, but this is a simple procedure. On the left, that's supposed to be a foot, and there's a little drop of blood there. So included in the kit is a volumetric inoculation loop, which picks up exactly 1 microliter of blood. You then take that blood and mix it into 6 drops of water in a little sample vial, which is included with the kit. You put the strip into the water, and you read the result in 5 minutes. So it's an extremely simple procedure, and these are your typical results. So if you look at this bank of strips on the left, and remember, the missing line means positive result. So your typical results that you will obtain are either homozygous A, AS, AC, homozygous S, SC, or CC. And since, again, it's a competitive immunoassay, you look for the missing line. So homozygous A, you will only miss the hemoglobin A line. If you're trait positive, you'll simply be missing the A and the S line, and et cetera down the line. If you have sickle cell disease, only the S line will be missing. This just shows that in very rare cases, you can have an invalid test. So if your control line ever does not show up, it likely means the liquid did not flow up to the top of the strip, or the strip was taken out of the liquid before 5 minutes. I've had this happen where people are just so excited to look at it that they take it out immediately. You have to keep it in for 5 minutes. So in this case, you would just have to run it again. And if you ever are not missing any line, either no blood was transferred to the sample, or there is an extremely rare hemoglobin phenotype in existence, which needs to be just retried once to make sure. So I won't bother trying to explain these lines because you can't really see them, but what we did was we spiked blood with, we spiked AA blood with SS blood, for example, to determine the limit of detection of the test for hemoglobin S, and vice versa, different combinations for hemoglobin A and C. And the final data is shown here, where our limit of detection for hemoglobin A is less than 2.7%, which means in any particular sample, if the concentration of A is at least 2.7%, we will properly diagnose that phenotype, and less than 3.3% for S and less than 1.3% for hemoglobin C. Since the test relies on very specific monoclonal antibodies, the test is blind to hemoglobin F, so there's no interference from hemoglobin F. And I forgot to mention that all this data is from a collaboration with Charles Quinn from the University of Cincinnati. So please refer to this reference for a more detailed explanation of this data and further information about the patient cohort, because we have tested, well, I'll show it, I guess, on the next slide. We tested 100 samples of blood. These were from patients all the way from newborn to elderly age, different concentrations of hemoglobin F up to above 60%. And 100 out of 100 samples were correctly diagnosed with the 6 hemoglobin phenotypes that are measurable. Two independent observers looked at the results on the strip, and there were no discrepancies among their interpretation of the results, and these were compared to confirmatory testing of electrophoresis and HPLC. So this just shows that if the patient was homozygous A, we properly, in every case, the test identified them as A, and all the way down the line, AS, AC, SS, SC, and CC. In every case, they were correctly identified. So just a word of caution, however, is that the test is not invincible. So there are other hemoglobin variants that the test will not pick up that do have some prevalence in parts of India, for example. So hemoglobin D Punjab, since the amino acid that is bound to by our antibodies is actually wild type, our test will diagnose patients with D Punjab as having A, hemoglobin D will be diagnosed as A. And the same thing goes for E, O Arab, and I. These will all be diagnosed as A. So it's very important in regions of high prevalence that the users recognize that. And another thing is I've spoken to multiple people in the audience who are really gung-ho about this test identifying beta thal. And we recognize that and are working on that in the future, but at this point we cannot identify beta thal with this test either. So that's just a word of caution for users. So to wrap up, the key features of the test are it's simple and rapid, 3 steps. This is actually 5 minutes, not 10 minutes. That's inexpensive. So we're currently only in pilot scale manufacturing, and we're producing the test with a projected end user cost of $2, under $2. So once we scale up to a typical manufacturing scheme, we anticipate that price will be lowered. And if NGOs get on board and start subsidizing the cost, that will of course go even lower. The test is highly convenient. There's no power or refrigeration required. No buffers, no liquid reagents are necessary. Highly stable for an indefinite amount of time at high heat and humidity. It's just a simple little paper strip. It can be used at the point of care in 5 minutes. No sample delivery is necessary. The doctor can incubate for 5 minutes as the doctor is counseling the patient for other issues. And of course, the test is highly accurate, 100% clinical accuracy, 100% specificity, 100% sensitivity. Very low limit of detection for the 3 hemoglobins that we have mentioned, and no interference at all from hemoglobin F. So this is my contact information. I have sample tests in my bag. You might have seen me sticking myself and testing around the conference. I'd be happy to show you samples if you're interested. And thank you very much.